All right, so we had a ton of great questions posed. The top 7 we're presenting here. So the first one is to create a menu of lifestyle options or work options based on the stage of life. This came out of a Take 2. All right. So many great questions were raised. The top 7 we're presenting here. So the first one was to create a menu of lifestyle options or work options based on the stage of life of each physician. And this came from a survey that was released through ASAP that basically looked at generational differences and what might be the drivers for burnout. A little bit more elaborate on that, but I don't know if, Jay, did you have any other elements of that survey?
Just that issues, the challenges that people face vary tremendously based upon whether they're fresh, whether they're resident, whether they're fresh out of school, whether they've been in practice for less than 6 years, 6 to 15 years, 15 to 25 years, or more than 25 years. And so if we talk about burnout, burnout is not the same for all emergency physicians. And if we're going to crack solutions, those solutions really have to be based upon the challenges and the cost of burnout to the physician at her or his particular stage of their career. And so one of the things we talk about is, number one, all we have right now is that ASAP survey. Should we have a better survey looking at exactly what are the issues that cause burnout for physicians at different stages? And once we have that, then we develop a toolbox of solutions for those physicians. And by the way, toolbox may not be just personal. We're not just talking personal issues in terms of yoga, et cetera, We're talking about for our young physicians, debt is a major issue. We know it is. Average debt in the study from 2 years ago of emergency medicine residents, their average debt is $212,000. That's an average debt. 37% of young emergency physicians rank debt as a major issue for them, which is significantly higher than any other generation. And so maybe we need to craft some solutions specifically for those, for that group, for example.
One of the other potential avenues of research that was posed is what is the correlation of physician burnout and the perception or experience of your students. So the idea here is for those of you in a teaching capacity or for anybody in a teaching capacity, depending on the level of burnout that you're experiencing, are your students seeing you as inaccessible? Are they seeing you as, there are some extreme words such as like, are you, is there like inappropriate treatment of students? Are you able to, basically answer questions? Are you able to integrate the students in the experience? How are you seen by the people that you are teaching?
The next one, near and dear to my heart, is how to create a win-win situation with our consultants. This can be expanded in a variety of different ways. And an area that I'm interested in personally is how to reach out of the emergency department silo. How do we affect change in the other specialties as well? And it could be as simple as looking straight up into starting with dealing with the consultants at the bedside and exploring their world to try to improve their experience coming down to the emergency department visiting us, and vice versa. How hopefully they'll look into introspect in terms of finding ways to improve their interactions with us to make the whole experience much better.
So number 4 was how important is shift overlap? If I'm remembering correctly, this was brought up in the sense of, how many patients are physicians seeing, how many patients per shift, and then towards the end of a shift, is there a cap at which point you should stop seeing patients? Is there a certain amount of time that you can put in between each individual's shifts in order for them to feel less burnout, for the patient outcomes to be better, and so on, handoffs to be better?
Next up is pretty straightforward. If physicians takes breaks, are there any patient safety issues with that?
So number 6, we wrote balance responsibilities, and then in parentheses, don't add trade. So this is the idea that you have a certain amount of asks on your time at any point in time, and it's usually divided between different responsibilities like teaching or clinical work and so on. And one thing that a lot of us have a really hard time with doing is saying no. So maybe instead of saying no, you could trade responsibilities. If you're saying yes to something and you're bringing something into the amount of task burden that you have, is there something that you can trade away so that you don't have to say no, but you still are maintaining the level of balance?
There was one paper by a cardiothoracic surgeon where he likened his responsibilities to his financial portfolio, and if his financial portfolio is balanced, then all the different areas would be in balance and would do well. But if one became imbalance, what you would do is talk to someone, get some wise counsel, and try to change how to balance things. And so the concept here was also, what about the concept of a life coach or a mentor, not just for our residents, but mentors for our attending physicians who usually serve as mentors. Maybe they should have mentors as well.
And finally, we explored the concept of mandating no nights after a specific age, whether it be 50 or somewhere around there. And obviously this would be determined based on a physician's choice. And this one ties somewhat quite nicely into this curated lifestyle of emergency medicine that we're contemplating exploring.
Responsibilities, educational or teaching responsibilities, and research responsibilities. There is not a lot of research on any of those topics, so it's really like a wide open range. So if people are interested in doing it, we did do a I shouldn't say severe, but a deep literature research on those specific topics, and there's not much. So go ahead, be on your way, enjoy.
All right, anything else for Dr. Kaplan's group? All right, where is Dr. Chung? I'm going to put you up next.
I recognize this is going to be very tiny font for those of you in the back, but that's okay. That's why I'm going to get up here and talk. So our group was tasked with looking at the personal factors on the National Academy of Medicine model for well-being. And we discussed this at the brief intro of our group, where once upon a time, this particular subcommittee was wellness, right? This is what we thought wellness was. And for those of you who are familiar with the ACEP wellness wheel from a few years ago, there were the 7 spokes. It was like physical wellness and mental wellness and occupational wellness and social wellness and financial wellness. And well, that is basically our subcommittee. And since then, we've recognized that, wellness is obviously a lot more comprehensive than that. But in some ways, this group was a little bit of going back to basics. And so we charged our consensus group members really with 2 tasks. One, to try to figure out, are there areas that have been researched to death and that we know probably far more than we ever need to know about, for example, mindfulness, just to throw one out there. And are there areas that in our hurry to find a systems-based solution that we've completely overlooked? You know, a personal factor that has come up is related to diversity and inclusion, right? And now we're kind of backpedaling towards that and recognizing that that is important, but I think we missed it in the first go-round in our rush to get to the systems-based solution. So that's kind of what our group was looking at. We, you know, we went through the different descriptors for the National Academy of Medicine model, and we kind of grouped them into 4 large groups. The first one being, what was the first one? Social support. I think social support was the first one. So that was really like, what are your mentorship networks? Do you have a sense of belonging? Looking at tribalism and social support, both within the ED and actually outside of the ED as well, so your family support structures as well. It was sort of group 1. Group 2 was looking at joy in work and engagement and a sense of meaning and a purpose and a calling towards medicine and towards your job, towards emergency medicine. Group 3 was focused primarily on individual personality traits. So what is your Myers-Briggs score? How high is your emotional intelligence? Are you an introvert? Are you an extrovert? And looking at those types of factors as they relate to wellness and burnout. And then finally, we had a very tiny group of finances which didn't really fit into any of the previous 3. And so we actually had spent most of our discussion talking about the first 3, although we did collect some data on the financial wellness as well. And out of all of this, so we did the 1-2-4 model. Well, for some of the groups, we did 1-4 because we got so excited. Well, I got so excited that I forgot about the 2. And so we came up, and at the end, we had put everything up on these large Post-its, and everybody kind of got to weigh in as far as what they thought the priorities were. And so we've listed here our top 7 out of those 3 groups of items that we discussed. The first one, I guess we'll talk about sort of going to the joy in work group. Are there things that we need to look at further with regards to joy in practice and gratitude and sense of meaning? And the 3 questions that came out of there were, 1, does expressing gratitude in work towards others increase your own joy in work? Does involvement in your patient's community change your joy in work? And 3, a more broad question and perhaps less targeted than the other 2, which was how do you retain a high sense of calling, whether it's you're a learner, you're a medical student, how do you, if you have it as a medical student, how do you retain it as an attending going forward? Looking at social support, we spent a lot of time talking about mentorship in particular. Some of the themes that came out were looking at informal mentorship networks. So we all recognize what a formal mentor-mentee relationship is. It's someone you go up to, it's like, hi, will you be my mentor? And here's my contact information, and you set up a whole agenda. Or it's someone that you're paired with, whether you're a resident and you're paired with a faculty member, or you're a junior faculty paired with a senior faculty, or you do the speed mentoring program at SAEM. There's lots of formal mentorship that is out there, but there's also a lot of informal mentorship that we discussed, and that it's a lot of people that we work with and that we interact with on a day-to-day basis who we wouldn't call them our mentors, and yet every day we're asking them for advice, we're asking them what they would do in this situation, we're asking them like, hey, can you look at my CV? Hey, oh, you heard about this opportunity? Thanks so much. And we interact with them on a day-to-day basis in so many small ways that we may not necessarily consider them our mentors, and certainly peer mentors, I think, fall into this category a lot, where we think of a mentor as having to be someone very senior, but certainly a peer could be a mentor as well. So looking at these informal networks and how do we choose those informal networks, and do those informal networks have an impact on our wellness? Tagging along with that and looking at informal networks, they don't have to be in person. We also spent a lot of time discussing the impact of social media and technology on mentorship, which is actually a relatively new and unexplored topic. And so now with the advent of, say, Twitter and Instagram and Snapchat and Facebook and all these other ways to access mentorship, people are certainly exploding their networks of informal mentors, but is this actually increasing well-being? Is it actually increasing people's joy, people's purpose in work, and their career development? This one we should save for last. Okay, and then the final category was looking at personality traits. We spent a lot of time being like, actually going back and forth about the Myers-Briggs and different things like that, and we all decided that we probably shouldn't limit medical school applications to a Myers-Briggs test. It's probably not a good idea. And we spent a lot of time sort of hashing that out. One of the things that did come out, though, is that maybe we should be assessing people a little bit more individually, specifically with something in regards to communication. How do people communicate well? Are they... you know, do they need to check in after every single patient? Does a resident need to check in after every single patient, or are they kind of like, I just want to fly solo, leave me alone, I'll come find you if I have questions? And actually, having a formalized assessment for that, and then being able to identify, like, oh, Nicole is likes to communicate a lot face-to-face, and so we'll communicate a lot face-to-face, and she likes lots of feedback, and so we'll do lots of feedback, as opposed to somebody who's a little more introverted and maybe would prefer to just have one big wrap-up section at the end.
And so part of the individual factors and something that we discussed was what's overdone, and we kind of decided that looking at individual factors of wellness and whether or not you are an extrovert or an introvert, and if that directly ties to wellness or burnout, it's not really the direction that we kind of wanted to focus on. But this is an example, and it feeds into our last kind of big idea of, once you get data, what do you do with it? So you can do a personality assessment, you can do an assessment for emotional intelligence or a values assessment, et cetera. And then once you have that information, what do you do with it? And it's that you look at the individual factors that your learners or that your colleagues have, and you use an individualized approach to their wellness. So as Arlene discussed, it's kind of an individual communication style assessment, and how does that change how we communicate with each other to improve, wellness in both directions. The last idea is creation of a Wellness 360 evaluation tool, and what would we include? So when we sit down with someone at a performance review, whether it's faculty or student, and we look at their individual factors and say, look, you sort of garnered a lot of, let's say, patient complaints or nursing complaints over the last 6 months. Let's look at why. Is it because you actually scored a little bit lower on your emotional intelligence assessment? And instead of sort of yelling at you and making you feel poorly that you need to communicate better with the nurses, let's actually work on the foundational problem, which is some of your awareness, and let's try to build that up so that you can have these improved communications and these improved relationships. So developing a tool where it's a 360 approach to their wellness and some of these individual factors that they have and kind of what's going on a more personal level.
Anybody else? Any questions? Thank you.
Mentoring. Yeah, I had a question about mentoring, and I'm not sure, again, I'm a non-medical person, so this is more of a lay question, but I know in the corporate world we're moving more or talking more about sponsorship versus mentorship. And with sponsorship, that person is a little bit more vested and can give you more honest feedback and kind of help you through your career path. Is that something that's also in this field?
I think that's an idea that's kind of growing, and Felix is probably one of the biggest experts I know in terms of talking about how you build your support system. So you've got formal mentorship type programs, and you also have something that he talks a lot about, like building your personal board of directors or building your personal learning network. And that's kind of like who you formally or informally reach out to. But there are differences between counseling, mentorship, and coaching. And you sort of go to different, and sponsorship, and you kind of go to different people in your life to satisfy these relationships. But it seems really that mentorship is really the only formal process that we have in place for any of those 4 categories. Some people are trying to institute more formal processes for counseling, and how do we obtain that in a way where we feel psychologically safe and it's applicable to our lives. But then it may be valuable to look into how do we build up some of the pillars of sponsorship and also kind of more of a coaching model, which is very in place in the corporate world, but is overall probably pretty lacking in the medicine world.
Thank you. Okay, last but not least.
All All right, our group was tasked at looking at skills and abilities, and before we got here today, what we did is we did an extensive literature search using mesh headings on 12 different factors to try to kind of identify what were the key factors that we should be looking at, because there's not much research related to those. And the 4 factors that we identified were mastering new technologies, delegation, organizational skills, and optimizing workflow. And then today in our groups, what we did is we actually looked at each of the individual factors using the DAD and the 2510 to come up with some questions. And I had to applaud our group. We had a wonderful group. Now we're throwing competition into the wellness too. No, but we had a wonderful group. We came up with tons of great questions and some great solutions as well. And once we went through each of the factors, then what we did is we looked at everything and we tried to kind of, see if there were any threads that we could identify within each of those 4 factors. So I'm going to tell you about those common themes that came out. For mastering new technology, we had focus on email management, time management, and EHR coaching and how those things would affect our wellness. For delegation, there was identification of tasks to delegate, skills related to delegation, which tasks delegated to us can impact our wellness, and then criteria for delegation, and is there a metric out there for delegation? I got to say, we came up with a lot of questions around delegation, but that was a difficult one initially to wrap your head around as to kind of how to develop some of those questions. For organizational skills, we had defining key organizational skills and how to teach them. How can coaching affect, organizational skills and well-being? And how can we do self-assessments on our own organizational skills? And then once we do that, are there some interventions that we can identify to kind of help us and then really kind of impact our wellness? And then for optimizing workflow, we talked about triage doc and impact on workflow and how that can be tied to well-being. Optimizing the physician-patient ratio and how that can be tied to well-being as well. And the distribution of managing teaching in the clinical and sort of the clinical tasks we need to do also, those responsibilities and how that kind of impacts our well-being. So those were kind of the general themes that we came up with. Anything else, you guys?
I just wanted to thank all of the group members for our discussion group, because we had a very lively group, and I just want to thank you for all the talent and expertise that you brought to the table. So thank you. And I also want to thank our team members up here.
Thank you, Saadia. She was our captain.
Okay, so now the fun part of how do we pull all of this together into a cohesive document, a series of prioritized initiatives. There's a lot of good stuff here. So I believe what Dr. Manfredi and Dr. Sikora have decided is that we are going to ask you to look at all of the ideas that have come out of these. We can go through them all and give you a chance to ask questions, just as a quick reminder of what was out there since the morning sessions. And then everybody's going to get, like some of you did with your breakout sessions, dots. And you'll be able to vote. So you'll get 12 votes. You can put all 12 votes on one initiative if you think it's that powerful, or you can put one on 12 different initiatives, or any way that you want to break it up. So, and then of course we'll just look at which ones get the highest votes, and that'll help us determine which ones will move forward, excuse me, for the proposed research agenda for the consensus conference. Did I get that right? Sounds good? Does that match everybody's expectations from what we talked about last night? Okay.
Do people want us to go over what was written? So that's the morning wall. Okay? That's the morning wall. And you're going to have about 20 minutes. We're going to use this until the last presenter. Well, almost, because then we want to tally it up and let you know what the most final counts are. But do you want us to go over what we did this morning, or do you think just reading it will be helpful? Reading? Okay. So what we'll do is we'll just, like, as soon as that group is all set up, they have quite a few. So that was morning in the back, and this will be afternoon here and afternoon there. So you have your 12 dots, and just vote for those that you think have the highest priority.
Let's try to get all the afternoon on one wall. We can use the doors.
They have 12.
Over overachievers, type A's all the way. Okay, so let's put those, let's try to get as many on this side so that we're, yeah, I just wouldn't want you to put those on that wall. So, all right, so let me pass out the dot races here. Does anybody have any questions? Everybody understand what we're looking for? Okay, perfect. All right, well, everybody come get some dots. The colors don't matter, just whatever you've got. Again, one per idea or 12, whichever one. You've got 12 votes to cast however you want.